Hi everyone, let us discuss the pathology questions of the recently conducted Champions exam for INI-CET. The first one is from Hematology, where we have a 60-year-old patient having a very high platelet count of 8,50,000. We know the normal is between 1.5 to 4.5 lakhs. And along with that, there is splenomegaly. Genetic testing is showing us JAK2V617F mutation, which tells us it is a myeloproliferative neoplasm. And the bone marrow image that is shown over here shows the classical staghorn megakaryocytes. So now I'll show you a better picture also of the staghorn megakaryocytes, which are the precursors of the platelet, as we know, megakaryocytes in the bone marrow. Their nuclei are showing this kind of like the horns of a stag, horns of a deer. So staghorn megakaryocytes of essential thrombocythemia are very, very important. If in medicine you want to revise the criteria for essential thrombocythemia, please note the first two are to do with platelets, which means on a peripheral smear or a peripheral blood sample, the platelet count has to be more than 4.5 lakhs per mm cube, and this patient definitely qualified in this criteria. Next, when you look at the bone marrow, as I mentioned, you are supposed to see staghorn megakaryocytes. Some books also mention it to be as the multilobulated megakaryocytes, which means pretty much the same. This is regarding the morphology. Now let's talk about the genetic testing. Obviously, as I said, there is JAK2V617F mutation, which is most common, but apart from that, the MPL and the Kala-azar mutations can be seen. But what is it that is not seen and never seen in these diseases is translocation 922, that is BCR-ABL fusion should not be seen, because if this is present, then I will not think of essential thrombocythemia. Then my mind will always go towards chronic myeloid leukemia, that is the Philadelphia chromosome. So two things related to platelet and its precursors and two things related to the genetics, all this makes the major criteria. The minor criteria says that at least rule out that whatever you are dealing with, that is thrombocytosis, increase in platelet count is not reactive, because so many infections can increase the platelet count. Do you know iron deficiency anemia, which is the most common nutritional deficiency in our country, even worldwide, that can also increase the platelet count. So make sure you have ruled out these kind of reactive thrombocytosis. Okay, coming back, since we were here very close to the criteria of ET, that is going to be the answer in this question. Moving on to the next one, an easy one for everyone, I believe. Fine needle aspiration shows follicular cells, so dealing with thyroid, with nuclear grooves, inclusion, samoma body. Of course, this is characteristic of papillary carcinoma, and you know total thyroidectomy will be done. But over here, make sure you also read molecular testing, RET PTC gene rearrangement. Many students might get confused that RET gene is something that we study for medullary carcinoma, because ma'am, every time you had made us study one song and that song just never leaves our mind, is RET 10 med men. So I'll just repeat that song first to clear your confusion. RET is the name of the gene. I say whenever there is RET gene mutation, where is RET gene present on? It is present on chromosome 10, which is the thyroid cancer that it causes. If the mutation occurs, is medullary carcinoma. And which syndrome is this as a part of? MEN2A and MEN2B. But over there I said only RET gene mutation. Here they are saying RET gene has fused with the PTC gene. So this is a different thing that they're talking about. And PTC stands for papillary thyroid cancer. So if RET gene alone is mutated, I will think of medullary carcinoma thyroid. RET PTC gene rearrangement is done, I will think of papillary thyroid cancer. But I didn't have to go into so much of depth, because the nuclear features and samoma bodies are self-explanatory. So please note papillary carcinoma thyroid, which can occur following a history of radiation exposure, following a history of a patient having long-standing Hashimoto's thyroiditis, following a history of a thyroglossal cyst. If the most common genetic alteration is asked, it is BRAF mutation. If the other genetic alteration is asked, it is RET PTC gene rearrangement. In terms of the prognosis, you know this is known to have an excellent prognosis, one of the best cancers, if I can say so. Now coming to its morphological features, you can see that the nuclei are pretty much empty. You call these optically clear nuclei known as orphan annii nucleus. Inside the nucleus, we can also see certain inclusions. Inside the nucleus, we can see grooves, and that is referred to as the coffee bean appearance. Then of course the famous calcium bodies, which are referred to as the samoma bodies, but all of these are seen on biopsy, right? One thing that is seen extra only on FNAC is the colloid, because the colloid tends to get stuck in that needle of FNAC messy and it starts looking very stretched and stringy. That is known as the chewing gum colloid, which can be asked as a question in INI-CET. Moving on to the next question over here is about a kidney biopsy which has crescentric glomerulonephritis. As soon as they say crescentric, they're talking about RPG and either it's 1, 2 or 3. And then they say linear deposits that are present. Of course, they are talking about RPG and 1, which is the also other name of good pasture syndrome. What is happening in good pasture syndrome? The good pasture syndrome is going to have antibodies against the glomerular basement membrane, and that is what you found on electron microscopy also, deposits around the glomerular basement membrane. So basement membrane of course is affected. Why? Because good pasture syndrome is said to be the 1, 2, 3, 4 disorder. Let's revise that. 1, 2, 3, 4 means that it comes under RPG and type 1. It is a type of hypersensitivity 2 reaction. So hypersensitivity 2 means antibodies will be formed. There are antibodies that are present against which chain? Alpha 3 chain of which collagen? I mean, if you're talking about basement membrane, it is type 4 collagen. So over here, finally 1, 2, 3, 4 is done, but then basement membrane, if type 4 collagen is affected, basement membrane of only kidney would not be affected, right? Apart from kidney, even the lungs can be affected. So patient can have hemoptysis, patient can have pulmonary hemorrhage. So that is what they did. Anti-GBM disease, check for pulmonary hemorrhage, check for the anti-GBM antibodies. I hope this question is also clear. Just as a revision, because RPG and type 1 shows linear deposits, this is the image where you can see there is a green color line along the basement membrane. Same intensity of the green color line everywhere. There is no dark and light, no starry sky appearance. This is the classical linear pattern that you see in RPG and type 1 or good pasture syndrome. Moving on to the next question over here, which is a case of, if I can say the answer right away, and I'm sure you've been through the question in the Champions exam, that is autoimmune hepatitis. Now over here, please note, we have a 32-year-old woman who presents with fatigue and mild upper quadrant discomfort. Now laboratory investigations have shown that there is an increase in the liver enzymes, there is an increase in the immunoglobulin levels, the autoimmune, that is anti-nuclear antibody titer is high. The liver biopsy over here is showing us portal inflammation with interface hepatitis and plasma cell infiltration. Very, very important. That tells you about autoimmune hepatitis. They are saying that what is the diagnosis, what will you give as the treatment? Of course, you would want to start the patient on steroids because you want to suppress those auto antibodies which are causing the damage. So this is something which is very important. Make sure you go into autoimmune hepatitis, you go into these features because you are appearing for INI-CET, which makes these features very important. Number one, they mentioned interface hepatitis, which basically means that this, of course, what you know, this 3 structure over here must be the portal triad, and these are the hepatocytes or the liver cells that are present. I am saying interface. Interface always means a junction, and hepatitis, itis means inflammation. So I am going to see those inflammatory cells which are present at the junction of the portal triad as well as the hepatocytes, and you can see all these lymphocytes, not just lymphocytes and plasma cells are going to be a part of the interface hepatitis, and that is exactly what was written, interface hepatitis with prominent plasma cell infiltration. Thus I selected autoimmune hepatitis. Apart from interface hepatitis, what can also be seen is emperipolesis. What is emperipolesis? Cell within cell. So you will see that there will be a cell, of course, in the liver, it is hepatocyte, and what is it eaten up are those inflammatory cells, that is lymphocytes. So if you zoom in and you try to search for it, these big cells of course are the hepatocytes, and what they have started eating up is going to be the lymphocytes. But these lymphocytes are just present, they're not being destroyed. It's just cell within cell, no killing is happening, and that is emperipolesis. What else can you see in autoimmune hepatitis is hepatic rosette. I mean, rosette, you know, right? Just like rose petals are arranged in a round fashion, suddenly you realize that the hepatocytes, usually hepatocytes are present like this in cords, but over here you will see that the hepatocytes have started to make a rose-like round arrangement. Hepatic rosette is also seen here. Last but not the least, if I go back and I read the question carefully, they had mentioned that what if it is a primary biliary cholangitis? That doesn't show you this kind of interface hepatitis. What if it is hepatitis B? That doesn't show you interface hepatitis. In fact, hepatitis B is what I want to show you as an image. If it would have been the question, I would have seen the classical ground glass hepatocytes in hepatitis B, and that ground glass hepatocytes is because of the antigen that hepatitis B carries? We know it's the famous Australia antigen or the surface antigen, and there is a special stain. So obviously ground glass over here means that you are seeing extremely pink hepatocytes. But if you want to confirm that this is because of the surface antigen of hepatitis B, you would want to do a stain known as the Orsin-Shikata stain, again important for INI-CET. But was all of that mentioned over here? No. Over here autoantibodies were mentioned, interface hepatitis and plasma cell infiltrate was mentioned. So autoimmune hepatitis is the answer. Moving on to the next question, where you have a brain tumor which was surgically resected. I think you've got the image classically of a Verrucke body and positivity for S100. S100 positivity in this situation, because you're dealing with brain, it will indicate a neural tumor, right? But other than neural tumor, S100 can be positive in tumors of the cartilage. So all the chondro-related tumors are going to show this. And also S100 is positive in Langerhans cell histiocytosis. I know for Langerhans cell histiocytosis, usually you've read CD1A positive, CD207 positive, but then go lower down in your list in your notes, you have also written S100 positivity, which is important for you to know. Here you said neural tumor and Verrucke body. Of course, you're thinking of schwannoma, which has an excellent prognosis. Quickly going through what is it that you see in schwannoma? You see the two classical antennae A and B areas, right? Antennae A areas are known to have a lot of cells, means they are very, very hypercellular. Antennae B areas are said to be blank, means they are not having any cells, they are hypocellular. Apart from antennae A and B areas, we can see the classical Verrucke bodies. What are Verrucke bodies? You will see all the nuclei decided that we will stand in two parallel rows. These are known as two rows of palisading nuclei. So one row here, nuclei are all set in two lines. Where are the cytoplasm? The cytoplasm is in the center over here. So this is referred to as a Verrucke body. So if you look carefully over here, this one line over here are nuclei, this one line over here are nuclei, and what you have in the center over here, all of this area is referred to as the cytoplasm. Go back to the image that was given to you in the question. Here also one row of nuclei, and the entire cytoplasm that you have over here. So schwannoma is settled for you. Of course, excellent prognosis, S100 positive. I think we are good to go. Moving on to the last question that you had over here, something which always troubles you in hematology is going to be a 58-year-old man presenting with generalized lymphadenopathy and weight loss. Flow cytometry shows B cell population, because you know 1920, these are all B cell markers, also germinal center markers. They are negative for 5 and 23. Now that's very important, because they are also trying to rule out CLL for you guys, right? Because 523 profile together, whenever we say is positive for CLL, SLL. But further, the translocation gave the answer. Translocation 1418. Now there's no doubt it is a case of follicular lymphoma. I've always taught you these are the chromosomes that you have to learn for the exam. Firstly, whenever they will be talking about translocation of chromosome number 8 with any other chromosome, especially an even number, 8 looks like B, so you will be thinking of Burkitt's lymphoma. So whether they say translocation 8 with 14, or they say translocation 8 with 22, or they say translocation 2 with 8, any 8 and even number stands for Burkitt's. Now let's go on to the others, and I made you learn these chromosomes as ages, right? Chromosome 11, chromosome 14, chromosome 18. So this is the age of a child, less than 12 child. This is the age of adult, so two margins, child and adult, 11 and 18. And in between I picked up 14, because then I taught you that if you pick up two margins of your life, the time when you became a child, or you are at the end of being a child, because at 12 and beyond they don't consider you as a child. So till 11 you're a child, and beyond 18 you're an adult, right? So 11 and 18 are two margins of your life. If translocation 11 and 18 will happen, that is known as marginal zone lymphoma. If on the other hand 14 and 18 happens, these are two teenagers, right? So translocation 14 and 18, teenagers are best friends. Teenagers always only get along with each other. Friendly lymphoma, follicular lymphoma, which is there. Why friendly? Because it is said to have the best prognosis amongst these. And what is left? Translocation 11 and 14. So obviously if a teenager is made to be friends with a non-teenager, everyone will go mental, and hence mantle cell lymphoma. And I hope you also remember mantle cell lymphoma is positive for cyclin D1. Mantle cell lymphoma can also be positive for SOX11. Over here translocation 14-18 was mentioned, which classically tends to involve the BCL2 gene, and that all goes in favor of follicular lymphoma. So well, these are the questions of pathology that you had in the Champions exam. I hope you got them right. Wishing you all the very best for INI-CET. Hi everyone, let us now discuss the questions of microbiology in the recently conducted Champions exam for INI-CET. The first question, I hope you got this right because this is one of the first few bacteria that you read in bacteriology, and this was to do with Enterococcus, where they've clearly mentioned that there is a vancomycin resistance, reason being the presence of the VAN-A gene. So if vancomycin is resistant, what are you going to give? Of course, we are going to give linezolid. So the protocol goes in a way that we always start whenever we are dealing with Enterococcus. We are always going to start with the beta-lactam, that is penicillin, but now a lot of resistance is known, because of which we also give vancomycin. But further, vancomycin-resistant Enterococcus is upcoming, written as VRE, and that vancomycin resistance in the Enterococcus or VRE is due to a gene called the VAN-A gene. So if the bacteria has this VAN-A gene, what is the bacteria going to do? We notice the bacteria changes its cell wall. Normally, it has a cell wall configuration of D-ala, and till the time it has this, vancomycin can easily bind to D-ala and act on it. But because of this VAN-A gene, it has now changed from D-ala to D-ala D-serine or D-ala D-lactate, and now vancomycin will not be able to act on this. That is why vancomycin resistance will occur, and in case of such a resistance, the drug that you will be now giving to the patient is linezolid, which was the answer over here. If other questions are asked on Enterococcus, we know this does not cause hemolysis, which basically means that blood is not going to be broken. This is going to be a non-hemolytic bacteria. Next, when I look at the shape that they provide, it is a spectacle shaped bacteria. So you will see these clusters of two spectacles over here. And lastly, if you have to know the culture media on which it is grown, it is known to be the bile esculin azide agar. Even if you can't learn the full form, even if you learn BEA agar, that is good enough, as long as you know that bacteria are usually scared of bile, but this is a bacteria which says, I will grow in bile. I'm not scared of bile. I can easily grow in bile. And in bile, as you can see over here, it is giving a classical black color growth. So these are the images of Enterococcus that can be asked in the exam. Moving on to the next question over here is a 50-year-old man with chronic hepatitis B, and I have the report in front of me where they have mentioned that the surface antigen and the surface antibody both are negative. Further, what is positive is anti-HBC. So the anti-HBC means the core antibody is positive, and HBV DNA has come out to be positive. So in this situation, now if it would have, let me read what all is written over here. False positive anti-HBC result. Even if they are considering this to be false positive, if it would have been, then I wouldn't have got the HBV DNA copies, so that is ruled out. This is no false positivity. Next, if they are thinking of acute hepatitis, I would have definitely got the surface antigen positive, so that is also ruled out. If I would have thought of resolved hepatitis B with immunity, in immunization, I will always get some antibody titer positive, antibodies negative over here, and if it is resolved, then finding the HPV DNA copies, again not making sense. So by ruling out everything, which is pretty much the technique you have to apply in the exam, is I think this is a case of occult hepatitis B, where you have to monitor the patient very closely and you have to treat if the patient later on becomes immunosuppressed. So this can definitely have a relapse in that case. So remember, this is a case of occult hepatitis B. Moving on to the next question, a patient, so this image was not there in your test, I've added it for the discussion. A patient recently returned from the sub-Saharan Africa with fever and chills towards malaria is quite characteristic. Peripheral smear shows ring forms and banana-shaped gametocytes, which tells you it is a case of Plasmodium falciparum. ACT, that is the therapy that will be given. Banana-shaped gametocytes look exactly like this. I don't think there was any scope of confusion in this question, right? But if I quickly want to revise the three main Plasmodium species, especially if I want to revise Plasmodium vivax, Plasmodium falciparum and Plasmodium malariae, and I want to revise their trophozoite forms first. In Plasmodium vivax, it is simple. There is going to be one ring and one dot. That is how the trophozoite looks like. When I want to look at the Plasmodium falciparum, it's opposite. It has many rings in an RBC, and every ring has many dots. So many rings and many dots is Plasmodium falciparum. Plasmodium malariae, we had learnt mala band. So Plasmodium malariae is going to be band form, which means that instead of a ring, it looks like the ring has been, just pushed against each other. So now the ring is looking pretty much like a band. So Plasmodium malaria is going to show mala band form. These were the trophozoites. If I have to compare the gametocytes, whether it is Plasmodium vivax or it is Plasmodium falciparum, we have male and female gametocytes. In vivax, you can see the shape of the gametocytes is going to be oval, whereas in Plasmodium falciparum, you can see that the shape of the gametocytes monocytes is banana shaped, which was mentioned over here, and hence I could pick it up easily. Moving on to the next question that you have, and the last one is a 35-year-old man with acute myeloid leukemia undergoing chemotherapy, presenting with fever, cough, pleuritic chest pain and hemoptysis. So they've tried to give you a cancer and chemotherapy to tell you an element of immunosuppression and then tell you that there is some kind of infection that has happened ongoing, right? Then very classically, neutropenic. Obviously, neutrophil count is low, patient is going to have infections. The chest CT shows nodules of surrounding with the ground glass opacity. So they are trying to tell you the halo sign over here. What is the most appropriate treatment? Now looking at the clinical manifestation, looking at that how the patient is immunosuppressed, the answer over here is going to be voriconazole. Reason being, with the kind of the CT findings mentioned, the nodules that are mentioned over here with the ground glass opacities, we will think of aspergillus. Even if you weren't thinking, you had to actually go through the options and then think of what infections could you think of over here. And you know that nowadays for aspergillus, because of its chance of being invasive, the drug that is being given is voriconazole. Well, with that, we wrap up the questions of Path and Micro that were discussed and that were put up in the Champions exam, and I hope you could solve them. If you have any other queries, do reach out to me, and wishing you all the very best for the INI-CET exam. Hi everyone. Let's discuss the questions of the pathology subject for the recently conducted INI-CET Champions exam. Starting with the very first question, which is a pathology and surgery integration of a 45-year-old woman who's presented with a breast lump, and they've given you the immunohistochemistry report, a must-know topic for INI-CET. So ER and PR positivity is 85 and 70% respectively. And if we discuss this, for immunohistochemistry, there is a very important score which is particularly followed for ER and PR, and that is referred to as the all-red scoring. Well, this question has not been asked in the INI-CET up till now, but could be a very important potential question. And as per this all-red scoring, at least 1% cells have to take the brown color on immunohistochemistry for us to call it as positive. So over here it's 85 and 70, so definitive positive. Next, we look at HER2/neu, which is found to be 2+, and that is said to be equivocal. Ki-67 is found to be 25%. So if I discuss further that what is the status of HER2/neu on immunohistochemistry ever in a pathology report, if 0 and 1+ is written, that by all means it indicates that there is no HER2 amplification. It is negative. You will not be giving targeted therapy. You will not be giving trastuzumab. On the other hand, if you get a 3+ positivity of HER2/neu on IHC, it is a definitive positive and you will be giving the targeted therapy of trastuzumab. Where we are stuck is the 2+ zone, which is said to be equivocal, and when you're stuck, you will have to do some other technique to confirm it, and that is when we would go ahead and do FISH, and that is exactly what is done in this question. The FISH measure that is given is HER2 divided by chromosome 17 ratio as 1.5. What does that mean? In FISH, when we look at chromosomes and genes, the HER2/neu divided by CEP17 ratio is calculated. 17 because HER2/neu gene is present on chromosome 17. Now imagine if there is HER2/neu gene amplification, like in a case of breast cancer, automatically this ratio will be more, and if this ratio is found to be more than 2.2, that would indicate definitely that this is an amplification. But over here, since the ratio was less than 2.2, which tells us that okay, maybe on immunohistochemistry you thought is it positive or not, you were a little doubtful, but on FISH, because the ratio is less than 2.2, now you get to know it is definitely negative. So now my final result over here is that ER and PR are found to be positive as mentioned in the question, and HER2/neu is said to be negative. So definitely I'm dealing with one of the luminal categories, whether it is luminal A or luminal B. But now I have to see what is the Ki-67. Ki-67 less than 14% if mentioned, it would have been luminal A, and if it is more than 14% like in this question, it will be luminal B. So of course this is luminal B, HER2/neu negative. A quick review of the molecular classification of breast cancer, which is very important in surgery, as all of you know. The basis of this is asked as a previous year question. So you might feel that I'm talking constantly about immunohistochemistry, but originally the basis of this particular classification was not IHC. Originally it is based on gene expression profiling, which has been a recent question as well. But what we are doing in today's date as a surrogate and for ease is immunohistochemistry. Based on that, we have 4 categories which are mentioned in front of you: the luminals, that is A and B, then HER2/neu rich, as well as triple negative. So now if I go common sense wise, triple negative will tell me that all the 3 markers on immunohistochemistry are negative. HER2 rich will tell me that only HER2/neu is positive, positive and the other two receptors are negative. The luminals are the opposite of this. Luminals say that ER and PR is positive, whereas HER2/neu is negative. Then what is the difference between them? Between them, I'm going to pick up Ki-67. So your next question will be, what is Ki-67? If not mentioned as this, it will be mentioned as the MIB1 labeling index, and this marker tells me the proliferation index of a tumor. So if Ki-67 is less than 14%, I think of luminal A, which means it is less proliferative. And if I find Ki-67 more than 14%, then that means the proliferation is high, and that is luminal B, and that is exactly what was the answer over here. Also, just before I move on to the next question, where else in pathology do you study about Ki-67 or proliferation apart from breast cancer? And that is going to be Burkitt's lymphoma. Because in Burkitt's lymphoma, they say this is a highly proliferative tumor, and by highly I mean the Ki-67 nearly comes out to be 100%. Somewhere above 95% will be mentioned in the exam. Again, a very, very important question. Another thing I want you to note that please be very cautious when you read the question. Ki-67 is MIB1 labeling index. Do not confuse it with something known as MIC2, because MIC2 is completely something different, and MIC2 is the other name for CD99, and this is something which is positive in a bone tumor, that is Ewing sarcoma. So they sound very similar but are completely contrasting statements. Let's move on to the next question over here, which was again a question which was hemat, correlation and medicine as well. You have a 25-year-old man with a rapidly enlarging cervical lymph node along with all B cell symptoms, that is fever, night sweats and weight loss. A lymph node biopsy, which is everyone's favorite, starry sky appearance, has been mentioned over here. And why do I say starry sky? Because definitely the sky that is dark, all these blue color cells in the background, which are the lymphoma cells or the cancer cells, they are making up the dark sky. And on the other hand, I have some light cells in between. These light cells are nothing but the tingible body macrophages. Why do I say tingible body? These macrophages, we know they are foodies. They are always going to eat a lot of things. So whatever debris is present around it, all the macrophages have, if you look carefully, they have eaten up that debris. So this is known as the stars because they are light. So now over here, you must always know that the starry component refers to the macrophages and the sky component, which is dark, are all the lymphoma cells. So this is a classical case of Burkitt's lymphoma, and they've asked me that what further investigations would you do to know for staging? So of course, for staging, I would want to rule out two very important things. Is the bone marrow involved or not? Because of course, that is going to change the staging. So I'll do a biopsy. Second, I want to know if there is CNS involvement. So I'll do CSF analysis. So finally, option B is the answer over here. I hope all of you did not think diffuse large B-cell lymphoma, because that is the most common NHL worldwide. It tends to come to our mind. But over here, I'm seeing the classical starry sky appearance, which makes it nothing other than Burkitt's. Also, even if it would have been diffuse large B-cell lymphoma or DLBCL as you call it, I would not want to go in for cyclin D1 immunostaining. I mean, this combination is very weird, because DLBCL is not cyclin D1 positive. Cyclin D1 in fact is a marker that is for mantle cell lymphoma. So it's completely different again. Moving on to the next question, which is everyone's favorite, but usually you get it as an image-based question, and today you've got it as a wording and you have to do match the following. So how can we ever go wrong with TB? And the granuloma of TB has to have the word caseous in it. So if I look carefully, here we have a caseating granuloma, and that has a necrosis and the very famous Langerhans giant cells. How do Langerhans giant cells look like? The ones which are going to have the horseshoe shape arrangement. So of course, TB is sorted for us over here. Next, let us go to leprosy. Leprosy again is going to be something which is going to have granulomas. So one thing is certain, but leprosy has something called lepra cells or Virchow cells. And what are those cells? They are actually macrophages, and those macrophages have eaten up the lepra bacilli. So I see this written over here. Leprosy has acid-fast bacilli in the macrophages and granulomas. Usually these are the Virchow cells or the lepra cells. Moving on to the next one, and that is going to be syphilis. Syphilis is famous for gamma formation. So I have to search for the buzzword gamma over here, and that is where I find it. And do you know what kind of a granuloma does this gamma have? How is this granuloma of syphilis different from the granulomas of, say, a TB or a leprosy? Because this is very famous for having a classical plasma cell infiltrate. Moving on to the fourth one, who can get this wrong? Cat scratch disease is famous for its stellate granuloma. So that's the buzzword that you had to find over here. So you match it with the second one. I hope you know that stellate granuloma, apart from cat scratch disease, is also seen with lymphogranuloma venereum, which is a previous year question. Moving on to the next one, and that is going to be sarcoidosis. Again, very famous because it is going to have the non-caseating granulomas. So I can see the non-caseating granulomas mentioned in the first option, and it has a lot of macrophages because that is how overall granulomas are made. Another thing for sarcoidosis, which is very, very important, is that these tend to have naked granulomas. Now, what do I mean by that? Usually, when I say a granuloma, say a granuloma of TB is there or leprosy is there, every granuloma will be covered by lymphocytes. It's like a collar of lymphocytes that are covering. So, till the time the covering is there, it's like clothes are present on that granuloma. But now, if I say if the lymphocytes are missing, the clothes are gone, and that is what you call as a naked granuloma. So, that basically means that the lymphocyte or the lymphocytic collar is missing over there, and that is seen with sarcoidosis. Coming to the last one, and that is going to be Crohn's disease, a very famous inflammatory bowel disease. The hallmark of that is also non-caseating granulomas, and as I said, inflammatory bowel disease. So you're going to see that in the intestinal wall, and there you go with the fifth one. So finally, all your combinations are done. You can get image-based questions also on these, but when so many diseases are put up, almost every granuloma is going to look the same. So this is the best way they can give you. And INI-CET, two types of questions have become very famous. One is match the following, and the other is of course multiple options. So I have a few multiple options also, but let's go back to our UG days and do some assertion reason type of questions. So now we have an assertion which says that the cancer cells carry out something called Warburg effect, which is true. Warburg effect was given by the scientist Otto Warburg, and that says that cancer cells undergo a metabolic shift and they do aerobic glycolysis. So now the only thing that you have to know is Warburg effect is glycolysis, means utilization of glucose. Now you would think that cancer cells are using glucose because they need energy, right? They need ATP. That is what anyone would think of. But over here they are doing aerobic glycolysis because their primary motive is not only to derive ATP. Their primary motive is that while this process of aerobic glycolysis will go on, they will get some metabolic intermediates, and those metabolic intermediates will help the cancer cell in growing fast. That is actually the hidden agenda behind carrying out these aerobic glycolysis. It's not just the greed for ATP. So the assertion is definitely right over here. Let me see the reasoning. And they have mentioned in the reason that oxidative phosphorylation definitely produces more ATP per glucose molecule. However, it is not going to give the same intermediates that aerobic glycolysis is going to. So now I understand that it could have gone for a technique where more ATP would have been consumed or more ATP would have been generated. Cancer cell had that option, but cancer cell decided that no, my greed for ATP is not that high. I am more interested in metabolic intermediates rather than getting more ATP, because these intermediates will help me in rapid cell growth. So over here, the assertion and reason both are true, and reason is the correct explanation of the assertion. So option A becomes the final answer. I hope you remember the radiological correlation of Warburg effect. This is exactly how and what is the principle behind the PET-CT scan. In PET-CT scan, we give an injection of FDG, that is fluorodeoxyglucose. Why do we give an injection of glucose before doing PET-CT scan? Because we know that cancer cells will utilize the glucose. Cancer cells are always hungry for glucose, and that is the reason that Warburg effect is also referred to as glucose hunger. So I know that if I've given an injection of fluorodeoxyglucose, the glucose will be eaten up or taken up by the cancer cells, and I will see all those cancer cells on the computer screen. So I will know where all the metastasis has happened or where all the cancer cells have actually spread. Moving on to the next question that we have over here is a derma-path correlation. Something which always scares students, because whenever derma and path, two subjects are brought together, it creates a little bit of a concern and a challenge. So let's try to decode it. Over here we have a 65-year-old male, and there is a chronic sun exposure with erythematous scaly patch on the forearm, and a biopsy is shown. So this actually had to be cracked by looking at the biopsy. If I look at the biopsy, and I'm sure all of you are not very fond of the pink and blue, but let's try to decode it to some extent. Here I can see that there is an epidermal thickness, and almost the entire thickness is very busy. Something is happening out here. These are just not the normal layers of the epidermis that I studied in the first chapter of derma, right? I can see a lot of weird looking, abnormal, atypical, or what you call as dysplastic cells. And if it would have been actinic keratosis, because there is a chronic sun exposure mentioned, I can think of actinic keratosis, but then these cells would have been limited to probably the very lower part of the epidermis. Here it has consumed almost the entire epidermis. epidermis, which tells me that this is now a case of carcinoma in situ. And because I'm talking about skin, I'm of course talking about squamous epithelium. So this is squamous cell carcinoma in situ. And if I have this situation, I have a pre-malignant condition, I know after this the next step is that this will convert into a full-blown cancer. So I will be doing a surgical excision with margin so that I can prevent the cancer spread, cancer formation. So this is actually a question which you had to crack on the basis of the image provided. Not a very easy question, but definitely important for INI-CET. Moving on to the next one. So 2 tough questions I've got together. This is also something that you don't casually study on a daily basis, but they could ask you because Bethesda scoring or Bethesda system is something they have been asking you. Like for example, in Pap smear, Bethesda system for reporting has been asked so many times. I've taught you so many questions on the adequacy of Pap smear, but that is the Bethesda system for cervical Pap. Here in this question, they give you the Bethesda system for thyroid FNACs. So if you look over here, there is a 45-year-old woman who has come with a thyroid nodule and you have an FNAC fine needle aspiration cytology done. Look at the words given over here. This is a microfollicular architecture. What kind of a nodule are you thinking? Again and again, follicles are forming. I think this is some kind of a follicular neoplasm. This is just an assumption as of now. Let me read further. I see there are no nuclear features. So there are no grooves, there are no inclusions. What are they trying to rule out? Clearly, this is not papillary carcinoma. So now more my mind goes towards that, yeah, it is again and again follicular. I think this is a follicular neoplasm. So what am I supposed to do? What is the most appropriate Bethesda classification? When you are suspecting a follicular neoplasm, you have to go in for Bethesda 4, and this means you will require surgery consultation, because all of you know which is the neoplasm that can never be diagnosed on FNAC alone is follicular neoplasms or follicular carcinomas. If you want to confirm follicular adenoma versus carcinoma, you have to do a surgery, you have to take the nodule out, you have to do a histopathology examination. So always remember, follicular adenoma versus follicular carcinoma cannot be diagnosed on FNAC, and hence I selected a surgical consult thinking that it is a follicular neoplasm. So a very quick recap only for INI-CET of the Bethesda system and what you need to know for thyroid FNAC out of it. So over here, if you look very carefully, I have a total of 6 categories that Bethesda has given. The first one tells us that if you don't get adequate number of cells, you will label it as category 1, which says that either you've not got as many cells as you wanted in a thyroid smear or it is non-diagnostic. So that is category 1. In category 2, if you have something benign like a thyroiditis, Hashimoto's, lymphocytic granulomatous, so all those benign inflammatory autoimmune conditions come under category 2. Coming into category 3, which is very gray zone, where you feel that you can't even say it is a cancer, but then you can't even say that it is completely benign. So you're stuck in between. You definitely see some bad looking cells, but their significance is not known. ATP of undetermined significance comes under category Bethesda 3. Now coming to the fourth one, which was given in your question over here, is when you are suspecting a follicular neoplasm, you go for category 4 and you know you have to do a surgical exploration, you have to do a surgery of that nodule to be able to gather that whether it is an adenoma or a carcinoma. Moving on to the fifth one, when you have a suspicion of malignancy, obviously not the follicular one, you are talking about the other malignancies, but right now you are suspicious. You are not clear-cut sure that it is a papillary or a medullary. If you are suspicious, you put it in category 5. And if you are certain of malignancy, then you put it in category 6. Let's assume you were seeing clear-cut grooves, inclusions, then you knew it is a papillary carcinoma for sure, then you would have put it under this category. So this is a quick brief of, the different terminologies that are used under Bethesda. You just have to go through them once to be prepared for the exam. Moving on to the next question over here, again a very tough one. So I've got all back-to-back tough questions so that you just finish them off in one go, where you have a 60-year-old male patient presenting with progressive dyspnea and persistent dry cough. HRCT shows a bilateral honeycombing predominantly in the lower lobes, and they've given a lung biopsy. If I just look carefully to the lung biopsy, I know I'm not too good with pink and blue. So what can I gather out of it? Honeycombing is mentioned, and also before I come to this, I just had a quick quick look through of all the options. I have something called organizing pneumonia, usual interstitial pneumonia, NSIP or non-specific interstitial pneumonia. So basically, I am talking about ILDs, interstitial lung diseases. That is the categories, a topic which probably no one touches upon in pathology before any exam, but then this is INI-CET, right? So then I realized that because most of the options go in favor of ILD, at least one thing I should be able to rule out this I don't think is a case of hypersensitivity pneumonitis, because of course the word tells me that there will be some kind of trigger factor for hypersensitivity, and also this tends to very commonly show granulomas, and granulomas definitely are not there in this image that is given, so hypersensitivity is ruled out. Another thing that is ruled out is organizing pneumonia, because at least this buzzword you have to know that in organizing pneumonia you see very characteristic bodies called Mason bodies. Don't confuse it with the Mason-Fontana stain. I hope you remember Mason-Fontana is a stain for melanin, altogether different game. This is Mason bodies which are nothing but foci of fibrosis. I don't see any large chunks of fibrosis in any of the spaces. So Mason bodies not there, organizing pneumonia ruled out. Now I have two things left. Either it is a case of usual interstitial pneumonia, or it is a case of non-specific interstitial pneumonia. Now please note, usual interstitial pneumonia shows something called as temporal heterogeneity, which means that everything is not going to look the same. Like you see in this photo, you have certain cystic spaces, then you have certain foci of fibrosis also there. So the fibrosis is there, but it's not diffuse, it's not present homogeneously everywhere. There is heterogeneity present, so that is why I would go more in favor of usual interstitial pneumonia with a poor prognosis that it carries. If it would have been a homogeneous or a diffuse fibrosis, I would have thought more in favor of non-specific interstitial pneumonia. Do I want you to study this in more depth? No, only this much of information is more than important and more than required for you. Moving on to the next one, I suppose this was an easy question for you in the exam. A patient with hematuria, so one organ is clear, that is kidney, with hemoptysis, the other organ is also clear out here. As soon as these two come, I have 2-3 differentials coming to my mind. Either it is a case of Goodpasture syndrome, right, because these are the two organs affected. It could be a case of Wegener's granulomatosis, because in that also the same kidney and lungs are affected. So let me read further. I see that the serum creatinine has definitely been increasing. So that tells me, of course, kidney is going for a toss. Urine analysis shows proteinuria, dysmorphic RBCs, RBC cast. So I am now definitive that this is going in favor of a nephritic syndrome because of so much of blood coming out. And further, they say that there are crescents. Now when they say crescents, they're talking about RPGN. So I know that RPGN 1 hai, so it is a case of Goodpasture syndrome. RPGN 3 hai, then it is a case of Wegener's granulomatosis. I'm still stuck in that dilemma. Further, I went in for immunofluorescence, and that shows me linear deposition of IgG along the GBM, glomerular basement membrane. Now I am certain that Wegener's is ruled out. Why? Because if there are antibodies against the glomerular basement membrane, anti-GBM antibodies are present, that is definitely a case of Goodpasture syndrome, and that is referred to as RPGN1. Let me show you a picture of RPGN type 1 which shows you a linear immunofluorescence. Linear means that, see, where is the glomerular basement membrane? Along all the capillaries, the basement membrane is there. So now you will notice that the green color is going to be present as a line everywhere, just along the basement membrane. So if you look carefully, I took a green color pen and I have drawn a line along the entire basement membrane, and that is the anti-GBM antibody disease or Goodpasture syndrome, which involves both the kidney and the lungs. That is why hematuria as well as hemoptysis. Why did I rule out Wegener's granulomatosis? Because that is a case of RPGN type 3, and RPGN type 3 does not show any immunofluorescence. Immunofluorescence should have been nil. Then I could have thought of Wegener's granulomatosis. I hope this is okay with everyone. Let's move on to the next question. This is a question where you have more of an orthopath integration. A 20-year-old male presenting with progressive knee pain and swelling, and below is the X-ray of the patient's knee that you can see over here. Biopsy shows multinucleated giant cells in a background of stromal cells. Now, whenever they say this, of course, what's coming to my mind is a giant cell tumor and other giant cell lesions. You know, even a bone cancer like osteosarcoma, chondrosarcoma, aneurysmal bone cysts, these can also show giant cell-like tumors. tumors or like lesions, I would say. Giant cells can be present in them, but common things come first. Look at the location, look at the radiological appearance that is being given over here. So definitely somewhat very similar to a soap bubble probably is showing over here. If I go back and I read, I see multinucleated giant cells, of course seen in giant cell tumor, in a background of stromal cells. Let me show you a possible picture that could come in the next exam. This is the multinucleated giant cell and the background is showing me these stromal cells. So that means it is a case of GCT. Now, another question that is asked is that in giant cell tumor, you have these giant cells and then you have these single cells. Which of them is the tumor component? And usually we think that, oh, the word is giant cell tumor, so the tumor must be the giant cells. But no, the tumor is not the giant cell. Giant cells are just a reaction to the tumor. Who's the real tumor? The real tumor is actually the single stromal cells in the background. So these single nuclear cells in the background, these are the tumor cells, and these giant cells are just a reaction. Do you know the pathogenesis of giant cell tumor? It is actually the activation of a pathway called the rank-rankel pathway. They say that giant cell tumor or osteoclastoma is an increase in the rank-rankel pathway because of which the bone is being broken, osteoclastic activity occurs. That is why they've come up with anti-rankel drugs, which means that if you can stop this particular pathway, then the giant cell tumor can be controlled. And I'm sure all of you have read this, that there is a drug in ophthalmology called denosumab that they are using, which is an anti-rankel drug. Another thing, if I come back to the question, I think of osteoclastoma, I would want to go in for therapy. I would also want to go in for curettage. Now, if I look at the other things, can aneurysmal bone cyst also show me giant cells present in it? Yes, but aneurysmal means that along with giant cells, there'll be a lot of wide spaces having blood in them, which was not mentioned over here. Osteosarcoma definitely can show giant cells, but osteosarcoma will always show its hallmark, and the hallmark is osteoid. It is that thin pinkish color new bone that is forming, which was not mentioned over here. Next, talking about chondrosarcoma, I don't have any element of malignant cartilage mentioned, so the word chondro is completely ruled out. Finally done with this question. One more thing that I can expect for INI-CET is here they're talking about GCT of the bone. What if they talk about GCT of tendon sheath? What is the INI-CET question that can come? Of course, that is going to happen in the tendon sheath. It's not a bone tumor. It's a tendon sheath giant cell tumor. So apart from giant cells, what is that one characteristic thing that GCT of the tendon sheath is going to have? It is going to be hemosiderin. So that is one INI-CET question on microscopy. But why does this occur? What is the gene mutation because of which this can occur? Is the CSF1R gene mutation just something which is very, very important and a little tougher, a little extra info for your upcoming exam. Now moving on to the last question of pathology that was there in the Champions exam is about, again, it's more of a pharma question, but I just thought because non-small cell carcinoma of the lung, especially adenocarcinoma, is asked so much that I'll touch upon this, and I'm sure it will be covered in pharma as well. So over here you have a 55-year-old woman who's having this non-small cell carcinoma of the lung, and she's found to have EGFR exon 19 deletion, which usually adenocarcinomas can have. There is no ALK mutation or other gene rearrangements are negative. Another thing positive is PD-L1 expression. So now they've asked you what is the most appropriate, not just therapy, but the first treatment that you would be giving to her. Usually students have just mugged up one concept that, whenever cancer cells are expressing PD-L1, I hope you remember your neoplasia chapter, that whenever there is an increased expression of PD-L1, do you know what PD-L1 has an effect on our body? It is said to be immunosuppressive. So this cancer is pretty smart. Cancer knows that as soon as I will try to grow in this person's body, this person's immunity is going to come and attack me. So cancer said, let me get PD-L1 increased so that the immunity of this person is suppressed and his B cells and T cells cannot attack me. So cancer has got an 85% PD-L1 here. Your first thing will be that, oh ma'am, if I want to treat, let me give some anti-PD-L1 drugs and the cancer will be treated. But is that your first line of treatment over here? I mean, you can give it, but first line of treatment is not that, because over here, there is a classical exon 19 deletion in EGFR. So you will first give a therapy which is targeting that as the first line of treatment. And after that, you can give a therapy for PD-L1. So for anti-EGFR, option B is going to be the better answer that you have to mark in this question, and I'm sure you will be discussing this in pharmacology also. Well, that's a wrap up for all the pathology questions that were given in the Champions exam for INI-CET. Wishing you all the very best for the exam. Now let's discuss the microbiology questions that were given in the Champions exam. So starting with the very first one, which is nowadays a favorite trending pattern for INI-CET, where you have multiple options to choose from. It is based on bacterial anatomy and specially targeting fimbriae or pili. Let's go one by one. Are fimbriae made up of multiple subunits called fibrillins? That is wrong. It can be made up of pilins for sure, but not fibrillins. In fact, remember, number one, if they are made up of something, it is pilins, and also what they carry is an antigen. So they definitely have antigenic properties. So this statement is false. Then let's talk about their function. Are pili involved in bacterial conjugation? Well, that is correct. Do you know what pili are? They are very thin hair-like structures which a bacteria has, and they are involved in conjugation. Conjugation means that if one bacteria wants to give some genetic material to another bacteria, it is going to do so by creating a contact or a bridge, and the name of this bridge then becomes the sex pili, because let's assume the fertility is being transferred, and that is why they gave the name sex pili. So does it act as a contact? Does it help in conjugation? That is a correct statement. So I've got one correct here. Moving on to the third one. Are they involved in something else? Can they rarely be involved in motility? Because I always study that motility is a feature of flagella, right? It is done by flagella, but rarely can they also help in motility, and that is also correct. Because there is recently a question was asked in INI-CET that there is a special type of fimbriae or pili called type 4 pili, which is involved in locomotion, and that is specially found in Neisseria and Pseudomonas, and both of these have been previous year questions, and this is responsible for that twitching motility, especially in Neisseria that they talk about. So yes, this can be involved in motility. Correct statement. Moving on to the fourth one, which is also correct, is how would you detect? For detecting fimbriae or pili, there are two techniques. The first technique is said to be heme agglutination, and the second one is said to be surface pellicle formation. That is, on a liquid broth, it tends to form a surface pellicle. If I go back and read, definitely there is a pellicle formation, as I said, in a liquid broth or liquid interface. So this is also correct. The fifth statement is incorrect because they said pili are longer than flagella. No, whenever I draw a bacteria, you must have seen the flagella, which is going to be for motility, that is longer. Pili, on the other hand, are only for attachment and they are shorter. So now the only correct statements that I have over here are 2, 3 and 4, and thus option B is the correct answer. Moving on to the next was match the following of the transport media, starting with the Stewart media. Do you know Stewart media? Apart from that, another transport media that can be used is the Ames media, and that is used for the bacteria Neisseria. Whether it is Neisseria meningitidis or whether it is Neisseria gonorrhoeae, it can be used for both. How we had learnt it in the video lectures was A. mais is used in nice. A. mais is for Neisseria. Moving on to the next, the Venkatraman Ramakrishnan median is the transport media for Vibrio cholera, another very important question, the one that is famous for causing rice water stools. The third one is the buffered glycerol saline. Sometimes it is written as the complete name, that is Sachs buffered glycerol saline. Please note, Sachs buffered glycerol saline is for Salmonella and Shigella. So we've got the third one as well. Do you know one more transport media can be asked in the exam, and that is known as the Pike's media, and I think everyone knows pi for pi. So for Streptococcus pyogenes, it is going to be Pike's media. So this was a quick summary of all the transport media. Moving on to the next question over here, where a man has undergone a renal transplant, so they are trying to indicate immunosuppression out here. Then on biopsy, gram-positive budding cells with pseudohyphae are observed. So if only budding would have been mentioned, I would have called it that, oh, this is some fungus which is a yeast. But over here, pseudohyphae are also mentioned, so this is yeast-like, and pseudohyphae always indicates towards one fungus, which is going to be Candida. So now in exactly 2 minutes, we are going to wrap up all the images of Candida that are important for INI-CET. The first one, of course, is from gyne-path correlation or gyne-micro correlation, where you have the curdy white discharge, which is seen over here, and per speculum examination, very classical for Candida. So if you see a curdy white discharge, you will next be wanting to do a pap smear. On a pap smear, you will notice that the Candida, because Candida is very famous for having these long pseudohyphae, so that pseudohyphae is going to happen to be present in the center, and all the cervical cells will be stuck on it as if pieces of kebab are stuck on a stick, and that is why this is called as the shish kebab effect. And in case you love kebabs, from today onwards you might not, because I just compared it to Candida. So that definitely tells me that Candida has two things, those small portions are called the buds, and when the buds get elongated, they are referred to as the pseudohyphae, that was mentioned in the question. Well, it's a fungus, so which is the culture media that you're guessing out here? It has to be the SDA, Subout's dextrose agar. And what kind of colonies do you get? We get creamy, pasty, yeasty colonies of Candida. But if I want to differentiate between the species of Candida, each one of them is capable of giving a different color, and this colorful agar is known as the chrome agar. There are two more important tests for Candida. I've got you the same screenshots from your rapid revision videos because visual memory is very, very important. So over here we have the germ tube test or the Renal broad phenomena. That is very important, and that is shown by both, not just Candida albicans, which is the main member. It is also shown by Candida dubliniensis. Both of these can show you the Renal broad phenomena or the germ tube test positivity. Another thing which both of them can show positive is if I want to grow this in a nutrient deficient agar, that is going to be the cornmeal agar. As soon as I grow Candida in that cornmeal agar, it starts making these kind of spores which are double walled, and these are referred to as the chlamydospores. So now Candida turns out to be an entire KKK story like Kakako from Shah Rukh Khan movies, right? It shows us a curdy white discharge. It is going to show you the shish kebab effect. It is going to show you creamy pasty yeasty colonies. Chrome agar is going to be positive. Cornmeal agar is going to be chlamydospore formation. So now everything of Candida is going by the same alphabet. I think we are done with this question. Moving on to the next, an examiner's favorite bacteria, where we have an elderly male presenting with meningitis, and the CSF sample is subjected to gram staining and microscopy. The gram staining over here is giving a purple color. Purple color definitely tells me that I'm dealing with something which is gram positive, at least some place where I've got a hint, right? Now, which of the following characteristics? Meningitis, gram positive, and they're talking about motility with regard to temperatures. I know only one bacteria which can show this kind of a differential motility, and it can cause meningitis also, and that is everyone's favorite, which comes in every exam, called Listeria. Firstly, the kind of motility that it shows is referred to as the tumbling motility, and it is going to be motile at 22 degree, but it is going to be non-motile at 37 degrees. So now I want to give you a complete list of everything Listeria can do or can come as a question in the exam in one weird word. It is always learnt as A, B, C, D, E, F, G. What does that mean? And the most important thing is that it has a flagella. Because of that flagella, what is the motility? It is a tumbling motility. It keeps falling like that drunk friend of yours who binge drinks and just keeps falling left and right. Listeria is that drunk friend of yours, falling left and right. But then what would you advise your friend? That, okay, right now you're in your 20s, so you can drink your heart out. But once you reach your 30s, your liver's not gonna be by your side, nor is your metabolism, so don't drink then. So same advice I gave to Listeria, that while you're in the range of 20s temperature, you can afford to tumble and fall, but when you're in the range of 30s temperature, you can't afford to do. So motile at 20, 22, 25 degree, non-motile at 37 degree, and this motility is called as differential motility. For Listeria, please remember, usually this infection is happening after consumption of cheese or dairy products, especially the ones that have been kept in the refrigerator, because this grows better at 4 degrees. It tends to grow better at 4 degrees, and that is known as cold enrichment. And do you know, when someone consumes this kind of cheese, that person lands up with diarrhea. So if you have to do the testing of it, what are the tests that can be positive? It can be positive for catalase enzyme. It can be CAMP test positive. It is going to show you beta hemolysis. If you want to do an animal test, the name of the animal test is Anten test. And if you just want to do antibody testing, then you will be doing ELISA. So you see how an entire flowchart is created. So why should we leave the treatment behind? For the treatment, you use 2 drugs, and that is going to be ampicillin and gentamicin. Well, that's your flashcard for Listeria, something very important. Moving on to the next question, another important one, which was on galactomannan testing. This is done in the serum for what? It is done characteristically for invasive aspergillosis, and thus option C is the answer. So there are 2 tests in fungus that you will be asked in the exam. One is known as the beta-1,3-D-glucan testing, but this is not specific for any fungus. This can be done for possibly every fungus, like all fungus. I've just written it is positive, it indicates a fungus. So the question will be that is beta-1,3-D-glucan will be negative in which fungus, and we have learnt it as 3 very important. Bangalore Medical College, which means that B is for blastomyces, it will be negative for this. Next is mucormycosis, and the last one is going to be cryptococcus. So for these 3 it is negative, for everything else it is positive. On the other hand, if they ask you for galactomannan testing, this is for invasive aspergillosis. That is why in the market you will see the name of this test is aspergillosis Aspergillus galactomannan test because it is very much used for invasive aspergillosis, which is the answer over here. Moving on to a next question, INI-CET specific because very, very important and very, very difficult. So they've made an embryonated egg. They've marked all the important parts. You can see the, the developing embryo. You can see the yolk sac around the embryo. You can see the amniotic cavity. You can see the chorioallantoic membrane and the allantoic cavity. So all of that is marked. Now you have to see and tell that where would you cultivate the Japanese encephalitis virus. Please note that Japanese encephalitis virus comes under which category, and that is known as the arbovirus. And arboviruses are cultivated or grown in the yolk sac. So I can see yolk sac is written as option E over here, which is the answer. So if I quickly had to do a recap of the important ones, if I ask you that what are the bacteria or viruses that are grown in the yolk sac, so remember in yolk sac you are going to have CAR. Yolk sac you're going to have CAR. I gave you that mnemonic in the video lectures also, that in the car usually when you're with your friends and you're listening to loud music, you feel very cool and chilled out about it. So the cool sign is always yo, right? So always remember that yo in the car. And what is yo in the car? Yo for yolk sac and car for chlamydia, arboviruses and rickettsia. These are the ones which are cultivated here. Japanese encephalitis being an arbovirus, so I marked yolk sac. Now coming to the next. Around this I had the CAM, that is the chorioallantoic membrane. CAM sounds like camera. What is the favorite, at least for millennials, what is the favorite pose as soon as the camera is switched on and we don't know what to do with our hands? So we just make a V sign thinking we are looking very cool. And that is why with CAM we have vaccinia, variola, HSV1, HSV2. That is how we learn it. So as soon as CAM comes up, you will say vaccinia, variola can be grown in it. Along with that, HSV1 and 2 can be grown. Now let's go on for amniotic membrane and cavity and allantoic cavity. So learn any one. For amniotic membrane and cavity, I have learned influenza virus isolation, not the vaccine. The influenza virus can be isolated in the amniotic cavity, whereas everything else now goes under allantoic cavity, whether it is yellow fever, whether it is a vaccine for influenza, whether it is rabies virus. Now anything else will be asked will be cultivated in the allantoic cavity. So coming back over here, because yolk sac was asked, repeating once again, yo-yo in the car, so chlamydia, arbovirus and rickettsia. Moving on to the next question over here, which is about rabies. Before I get down to what is true and false, let me do a clarity in my own brain that you know what exactly is rabies going to do to the brain. Number one, as soon as rabies enters, they say, is it directly going to go to the bloodstream? No, I want it to go to the brain. So it will take a neural path. It will not take a bloodstream path. So statement 1 is false. Coming to the next one, rabies will initially multiplicate at the site of infection, then go to peripheral nerves, then go to central nerves. That is correct, because if I look at this over here, as soon as there was a dog bite, initially the virus was replicating over here, right? And after replicating over here, which is the receptor to which it got bound to? First, it is going to replicate over here. It is going to bind to acetylcholine receptors. Then in which way is it going to go? Of course, along the peripheral nerves, it's going back. It is going towards the central nervous system. So it's going retrograde and it is finally reaching the brain. And we all know in the brain, in the hippocampus and the cerebellum, there are very important bodies that you get to see called Negri bodies, right? So that is also settled for us. But once the rabies reaches the brain, after that, this means it has gone all the way back to the brain, retrograde, or in other words, the word centripetal can also be used. But once it reaches the brain, now it has to go out. If it has to go out, that means it now wants to travel to the eyes, it wants to travel to the salivary glands, it wants to travel to the skin and the hair follicle. So this is now going out, and that is why this is referred to as centrifugal spread. Now if I come back, definitely it is going to first replicate, then peripheral nerves, then going all the way to the brain. So can I say it spreads retrograde to the brain? It's going in opposite direction. Yes. Can I also say that it is going to bind to acetylcholine receptors? Yes. Now let's read. Is statement 1 true? Let me read one by one over here. Is statement 1 over here true? No, it is not. So I cannot select this as the answer for sure. Statement 2 is false. No, statement 2 is correct. So this can also not be the answer. Statement 3 is true. Yes, that is one correct statement that you see, and that's the answer. Then they say statement 4 is false. No, this is statement 4 is correct. So you realize this was such a multi-layered question. I had to first make sure that I've got my true false in place. Moving on to the next question, guys, over here is going to be something related to congenital congenital syphilis. Now, when I say congenital syphilis, I definitely had snuffles mentioned over here, runny nose, then I had bullous lesions, and then when we can see the periosteitis, we can see the saber shin. So now I know that I'm dealing with congenital syphilis. It's a simple one-liner. They've asked you which investigation is going to be done first, and either you call it screening or the first-line investigation for congenital syphilis, it is going to be VDRL. VDRL overall is always considered as a screening modality because this is a non-specific test for syphilis. When you have to do more specific tests for syphilis, then yes, you can do the FTA absorption test, you can do the Treponema pallidum heme agglutination test, but the screening or the first thing done for congenital syphilis is VDRL, which is the answer here. Moving on to the next question, which is all the trematode species and their host you had to basically mention out here. So yes, let's get going, but before I come to this, I will do the table, which is important. Whenever you have any trematode, make sure that the definitive host that you have marked in all of them is going to be the human being, and then there are two intermediate hosts, out of which the first intermediate host for all of them is going to be the snail. So this much of information is sorted. Now I have to only juggle between the second intermediate host. For schistosoma, there is no second intermediate host, so I'm not worried out here. For Paragonymous westermani, we have learnt it as Cara, so everything related to crab, crayfish. So para is everything crab, Cara, para, Cara, crab, crayfish. Moving on to Clonorchis anopesthorchis, which we've always changed and called it as Clonorfish anopesthorfish because here the second intermediate host is a fish. Coming to Fasciola hepatica, of course, which is in the liver, and Fasciolopsis buscae, which is in the small intestine, FAFA. Over here, what is going to be the second intermediate host is going to be fresh aquatic vegetation or fresh aquatic plants. So now that you know this, go back. Go to Fasciolopsis buscae. As I said, here you had to select the habitat. Hosts we've done, now let's do the habitat. Fasciolopsis buscae, as I said, is to do with the small intestine, so I mark it over here. Next, coming to Schistosoma mansoni. Schistosoma mansoni, I know three schistosomas. Schistosoma hematobium causes hematuria, so that must have gone to the urinary bladder, that is why hematuria. Then there is Schistosoma mansoni and Schistosoma japonicum, and I've always learnt IJ, which means that if they say which goes to the ileocecal region, it is going to be Schistosoma japonicum. Ileocecal means small intestine. Which goes to the sigmoidorectal large intestine region, that is going to be mansoni. So these are intestine related. This means I'm going to mark them with regard to the mesenteric veins. Next, coming to Clonorchis sinensis. See, what is the other name? Chinese liver fluke. Chinese liver fluke. So what am I marking this on? It is going towards the bile duct. And most importantly, what does it cause? It can cause bile duct carcinoma. It can cause cholangiocarcinoma. Coming to the last, P for P, Paragonymous westermani. P is pulmonary fluke. So this is going to go and involve the lungs, and that is where we've got our final answer. So you've done whether I get a match the following of hosts or I get a match the following of habitats. I think we have settled it all. Moving on to the next question, which is a previous year question from INI-CET, which they are saying that there is an inclusion body, and they've clearly mentioned the family that they're talking about, something to do with Rickettsia. So yeah, I can see the Rickettsia family member mentioned. Then I can see some miscellaneous members over here like Ulriccia. I can see Anaplasma. But over here, when I saw the cell I hope you know from hematology is neutrophil, and I can see something inside the neutrophil. So definitely Rickettsia is ruled out because this is famous for causing Rocky Mountain spotted fever, which doesn't show any inclusions. Now either it is Ulriccia or it is Anaplasma, but since they have mentioned neutrophil, it is a classical case of Anaplasma, because remember the way you write, and this is how I had taught you in the video lectures also, Anaplasma is always A for Anaplasma, N for the inclusions will be in the neutrophils, whereas when they're talking about Ulriccia, the inclusions are going to be in the monocytes. So let me show you the same image that you saw in your rapid revision or saw in your main videos. When you see inclusions in the neutrophils, you are thinking of Anaplasma. When you are seeing the same inclusions in the monocytes, you are thinking of Ulriccia. Here it was neutrophil, answer is Anaplasma. Moving on to the next question over here, a classical one of matching the controls and their respective sterilization technique. The first one is hot air oven. I hope you remember in hot air oven how hot? It is 160 degrees centigrade for 2 hours. And then finally the control is either Bacillus subtilis or it is Bacillus atrophius. If Bacillus is not mentioned, they will mention Clostridium tetani spores, which could also be an answer. Coming to autoclave. Autoclave is 121 degrees and 15, 15. So the timing is also 15 and the pressure is also 15 psi. So because temperature is high, 121 degree, the control over here for autoclave is going to be Geobacillus stherothermophilus spores. I hope you also remember the same Geobacillus stherothermophilus is the control for plasma sterilization also. Moving on to the next, membrane filtration. The filter size is always, I'm not writing, it's 0.22 microns, right? So you need something very small. That is why the control is Serratia over here. And lastly, for ionizing radiation, we had always studied Bacillus pumilus is going to be the control for radiation. So I've got my answer for ionizing radiation also. So definitely this particular table is done, but one last thing is left is what is the control for gas sterilization, which we always study as G for G, so that is Bacillus globigi. Moving on to the next question, which was a 25-year-old woman coming to us with complaints of abdominal pain and 6 episodes of passing dark stools, having mucus and blood streaks. However, there is no history of fever and tenesmus, which made me rule out Shigella, because whenever I have something like, dark red stools, dysentery, I do think of Shigella dysentery, but then that always comes with fever and tenesmus, which is ruled out. So at least one thing is settled. Coming to how did I rule out Giardia lamblia, because that usually presents with malabsorption. So fatty stools, that would be there, which is not mentioned over here. Further, if I see, there is tenderness that is present in the right iliac fossa. Some ileocecal involvement could be there, which goes very much in favor of Entamoeba histolytica, because that shows cecal involvement. It shows classical flask-shaped ulcers also in the region. So this, I think, would go very well with the history that is provided over here. Now, why is this not Campylobacter jejuni? Because over there they give 2-3 buzzwords when they want you to select Campylobacter. Firstly, this comes across as an acute food poisoning after consumption of undercooked poultry. Fever is usually seen, which is not seen in the image or the history over here. Also, Campylobacter jejuni, when they mention, they will say the culture is happening or the growth of this bacteria is happening at a classical temperature of 42 degrees. So you will say, okay, jejuni sounds like June. So June temperature is what, 42 degrees. That is where it grows. And the name of the culture media for completion is known as Campylobacter media. It can also be known as the Skyros media. These are also important for INI-CET. So definitely settled with this question as well. Moving on to the next question. So here we have a 30-year-old male patient with HIV having features of meningitis. CSF lumbar puncture was performed. HIV positive with meningitis. Definitely started thinking of cryptococcal meningitis, and the stain for it, of course, is India ink staining. We all know India ink is a kind of a negative stain, right? So before I move forward, I quickly want, because I have a couple of other stains and all of them are to do with fungus. So I'll give you an overview of all the fungal stains that are used in microbiology. Firstly, if you don't have any stain, you just have a if you classically see, there is a very transparent feel to this entire slide. It doesn't have any pink, blue, green color, because over here you have used a KOH mount, and KOH is just a chemical, it is not a color. Next we come to, if the fungus starts looking black, this means you have applied a silver stain called gomorimethenamine silver stain. If the fungus has started looking pink, then you have applied the PAS stain. Now if the fungus has started looking fluorescent, means you are using fluorescent microscope. And what is the fluorescent stain for fungus? It is calcoflower white. Now coming to the question of cryptococcal meningitis, if you have a CSF sample, then what you will be doing is the negative staining. And negative staining has 2 examples, India ink and nigrosin stain. Do you know they also ask you what is negative stain? So please be very clear on it that the negative stain is going to be where the background is going to be stained and this particular organism is going to be unstained. And they ask you that negative means you're doing the opposite. You're staining and giving color to the background, and the organism is going to be unstained. Moving on to, this is only done if you are using a CSF sample during this procedure. What if you have a brain biopsy and you want to see cryptococcus? Then you are going to use mucicarmine over here. So coming back, definitely I've got my answer, that is India ink staining is done as a negative stain for cryptococcal meningitis. Moving on to the next question, is a 20-year-old female from Africa presenting with hepatosplenomegaly along with pallor, means anemia, and lymphadenopathy. There is a high suspicion of Kala-azar, and they're asking you what all lab tests will you do. If you want to do an antigen test, especially if you want to do a rapid card test for Kala-azar, you do RK39 serological test. In fact, there's a very fun way of learning it also, RK39, although that's not the full form, but we've learned it, that it is a rapid card test for which disease? For Kala-azar. So RK39 is done. Ideally, where should you be taking? I mean, the most sensitive place to take a sample from is a splenic aspirate, although we don't take it because it's a very vascular organ and chances of bleeding I'm very scared of. But yes, you can do a splenic aspirate, but it has its own set of complications. So what I prefer rather than splenic aspirate is a bone marrow aspirate. So these are the three things that I can be doing over here, and thus option B is the answer. But whatever you may take as the sample, ultimately what will you be seeing on the image? We see the classical LD bodies because of course Kala-azar is caused by Leishmania donovani. How do they look like? If you look carefully, they are eaten up by a big cell, which is that big cell always ready to eat everything is a macrophage. And now inside them, I can see the LD bodies, which are not a single dot body. If you look carefully everywhere, you can see double dots that are present over here, the big dot and the small dot, the big dot and the small dot, and that is known as the LD bodies. If you are asked from microbiology point of view that what exactly is the LD body, it is going to be the amastigot form that you're looking under the microscope, and that is LD body. If you are on the other hand asked that no, I don't want to know microscopy, I want to know the culture. For Leishmania donovani, we are using the triple N media, and what is the form of Leishmania that you are growing on triple N culture media? It is then going to be the promastigot form. So please be cautious that under microscopy you are seeing amastigot, but on triple N media what you are growing is actually the promastigot form. With this question also done, we come to the last microbiology question of this particular champions exam, where a patient has come with pyrexia of unknown origin and they have probably suspected brucellosis, a zoonotic disease coming from animals. So now they've done serum sample. Serum means they're trying to look for antibodies, and you know the serological test where you want to find antibodies in the patient for brucellosis is standard agglutination test. So they realized that on a dilution which is just 1:20 or 1:40, they did not get any positivity in the test. But as they kept on diluting the sample to 1:80, 1:160, the test ended up being positive. So why is it that later on it came positive, and in the initial two testings of a lesser dilution of 1:20 and 1:40, there was negative, and this is referred to as the antibody excess. So this is the last and obviously a tough point that I want to tell you. In immunology, there is something called the Marek's lattice hypothesis, which tells us that you have to make sure that if you want, what are you trying to do? You're doing an antigen-antibody reaction. If you want a precipitin to form over here, be very, very sure that the antigen and antibody are present almost in equal amounts for them to form a complex. And that is why this is known as zone of equivalence. Zone of equivalence tells me that you can look carefully that if the antigen and antibody are roughly the same, you get the precipitin formation that is going to be maximum, and that is when you'll get the test positivity in your lab also. On the other hand, if for whatever reason, let's assume there is way too much of antibody, like this probably this patient had. If there is way too much of antibody, will you see any precipitin formation? No. So imagine patient has a lot of antibodies in his blood and still you are getting the test negative, because anything in excess, the precipitin will not form. So this patient had antibodies, but when you were doing minor dilutions of 1:20, 1:40, the antibodies were so much in number that the precipitin were not forming. When you diluted it further, that is when the antigen and antibody somewhere came in an equivalent zone, and that is when you started getting the test positive. So can I say if antibody is in excess, then also the test will not come positive? On the other hand, if antigen is in excess, then also the test will not come positive. And this phenomena is referred to as the prozone and post-zone phenomena. So if the antibody is in excess and the test is not, although the patient has antibody and still my test is coming negative, this is known as prozone phenomena, which happened in this question of brucellosis. On the other hand, if the antigen would have been in excess, that would have been known as post-zone phenomena. So please note, antibody excess or prozone phenomena that we saw in brucellosis is a very important potential question for INI-CET. Well, thank you for being a part of at least Path and Micro with me in this champions exam. I hope you did well and you learned from this discussion. Wishing you all the very best for the INI-CET exam.